And welcome once again to the CAHSAH Hospice Emergency Regulations podcast series, a special edition of At the Table with CAHSAH. We're doing 8, I believe, total podcast episodes along with the webinars, and we're breaking down California's new hospice regulations one section at a time, because that's all we can handle at a time.
Very true.
With the experts each week kind of giving us a rundown of what we're going to hear in the webinars, which will occur on the Wednesday following the podcast upload. And they will be live webinars, and you'll be able to hear a lot more about the specific regulatory requirements and the practical implications for your organization. And best of all, in my mind, you'll get an opportunity to do a Q&A, to ask some questions live. So, like I said, the webinar and this podcast explores specific regulatory requirements. Today, we're talking about, survey says, medical records, personnel records, office space, and administrative infrastructure. But here's the question I want to pose right up front. Can the infrastructure of your organization actually support the hospice that you're operating? Think about that. Because as we know, hospices can grow quickly. Censuses can increase pretty quickly. But sometimes the administrative infrastructure doesn't grow at the same pace. Personnel files might be incomplete. Documentation might be scattered across multiple systems. An office that worked for a census of 25 patients may look very different when you're caring for 150. So we're asking, does your infrastructure reflect the size, the complexity, and the responsibility of the hospice that you're operating? Joining me are two fantastic experts. We're having a wonderful time doing these podcasts. You should hear the stuff we talk about not on the air. Joining me again at the table are hospice expert Sharon Fredericks and hospice expert Eric Peterson. Welcome back to the table.
Thank you.
Thank you, Mark. Very, very kind words. Appreciate that.
Not at all. So, Sharon, do you want to do the big picture thing for us, or?
I think this is really, Eric and I were talking, kind of strange how we've thrown medical records into infrastructure. And it's kind of, I think in this series, when we really sit in front of the guests for an hour, there's going to be little snippets from everything else is filtered through. What it did to us as speakers is challenge us to maybe look at some of the regulations that we might have just said, oh, well, we'll get to that later, like medical records, et cetera. And yet there's parts of this that are extremely important, and you have to be in compliance for them, because you heard me earlier say, but a lot of the things that are said in here were what the anti-fraud team found. And so now it is in regulation to get us into compliance. And I think it will really help our operations overall. Like you said, do you have an infrastructure that can support your clinical care out there, education for your clinicians, and run a business? And that's exactly what's in some of these procedures and policies that we're going to talk about.
Yeah, I agree, Sharon. I think that's really nicely stated. And, while some things kind of are going to take higher priority than others, I mean, ultimately, we want to make sure that this is a well-rounded discussion to fill in all those kind of ancillary pieces that may not rise to the level of high priority or top priority. They are critical items to be mindful of. And so for those of you who are out there, who have read and understand, the regulations in a good sense, I mean, this is going to do a deep dive into the details of what needs to be done, what needs to be updated on policies, and ultimately what tangible implementation pieces you need to put out there for the public to see, such as your name, right? And your business hours. Are you aware that, your hospice medical director and the designee are two critical titles that have to be met on the application? And if not, they have to be updated on the application. What does that designation really, kind of drive besides, an application piece? Well, it affects ultimately how you handle your CTIs and the co-signature requirements. And so that's money, out of your pocket if you're not doing it correctly. potentially, and certainly a survey citation. So, we want to make sure that everyone has the intimate details to be able to take everything that's out there and look to put it into practice.
And I always like to say this just to remind folks that, administrative weaknesses eventually can become patient care weaknesses, correct? I mean, this isn't about just burdening hospice agencies. This is about improved patient care at some point. Yes?
Absolutely. And like Eric, when you were saying that you have to let CDPH know certain things, one of the things now that we have to do going forward is if any of your governing board members change. CDPH wants to know that. You have to notify them. And so to me, it's taking the leadership from the top and bringing it down, involving the department to say, you are doing the things right. You're getting better governing board members. You've gotten more. You've gotten some that have retired. It's like there's great leadership out there and you're grasping at it and you're giving them orientation and you're just doing better work overall. And that's your infrastructure. Can you support, like we've said, the clinical care that needs to be for your patients?
Absolutely. And I think too, if you're a CEO out there or an administrator, the last thing you want is a surveyor citing your leadership chapter as being deficient. Nothing's going to look worse to the governing body than you coming back with a leadership deficiency. So some of this stuff is low-hanging fruit that you can look to implement. But other stuff is going to require the active involvement of your governing body for policy approval, for where and how are you storing your medical records. You just don't want to be caught sort of with your pants down, and that's what we hope to help you avoid.
But think of how fast right now CMS is able to look at your records in real time, put analytics together that we still can't even imagine, I don't think. And yet your citation that leadership is not running the agency well goes directly to CMS. And they're going to sit there, they're going to pull your data the next morning probably. That's what I'm thinking is going to happen. Why shouldn't it? They know there's a weak spot, they're going to find more stuff.
Absolutely. And it's all driven through patient safety. For example, there's a slight change in your discharge summary requirements for live discharges.
Exactly.
Did you document clearly that your, attending physician was involved in the decision to discharge that patient live, not just to receive them back, right? So this is looking at getting away from, bad actors bringing people on and then just getting rid of them,
Exactly.
So you're going to be cited for that. And they may also flag you for well, what are you really doing over here? So the good agencies need to remain that way. And ultimately, protect yourself. The devil's in the details, and it's ultimately in what you write in your medical record content. So it's tremendously important. Everything that we're going to talk about is ultimately going to impact the boots on the ground folks as well. And your day-to-day operations from IDG to your daily documentation. So make sure your notes are being done in real time. They need to be done on the day of service, right? And if this is all new information to you, then I really hope that you sit in and take some time to listen to Sharon and I as we go into more detail on all the regulatory changes.
Okay. And it's something that I see more and more every year, and it's AI. I think there's sometimes an assumption that because the information is electronic and the record is automatically organized and complete, that might be a little bit dangerous. So the question is, can technology actually create a false sense of security, particularly when you're working with AI?
I would answer absolutely.
I'm looking at both of you, and it's like, okay, you've got thoughts on it, and it's either oh boy, this AI stuff is scaring me, or it's good for our business, it's good for patient care, it's good for workforce, but.
Yeah, I think AI is going to drive tremendous amounts of efficiency and staff satisfaction. It's going to help to, improve real-time documentation and the accuracy of the clinical record and help to hopefully capture, skilled services, right? And the nuanced items and aspects of the job that you do. You can look at a lot of medical records and know that, this is a stellar clinician out in the field based on what I'm reading, or think the other way. And the truth could be completely opposite, when you go and observe them out in the field, which is its own conversation. In the end, AI is allowable, but to me, it's like no different than like having a really smart friend that's sitting next to you that ultimately is an imperfect person also, and can make a mistake.
Hmm.
So you have to read and validate everything that's there, just like
Yes.
physicians who use verbal dictation. They sign an attestation that they've read, reviewed, and the accuracy of this record is signed, sealed, and delivered by them and their license. So the same concepts will apply here for AI, and will definitely help with your compliance and your monitoring. But you can't just trust that it's going to do everything perfectly or everything absolutely right. And that's what I'd say. The human element cannot be sacrificed when it comes to anything in our industry.
Well, I think I go back to when I first started decades ago in home health. Everything was handwritten, but yet still we'd make errors. And
Hmm.
so one of the clinicians I worked with had put together this whole little booklet of the errors that we were writing, which you would think would maybe, shouldn't be that many errors. And it'd be just hilarious. Pretty soon we were taking care of a dog versus grandma, because of the name or something like that. And we used to just sit there and laugh and try to find one a week for relaxation. I don't want to go back there with AI, but I agree, Eric, we have to be able to audit, make sure everything is in compliance before we submit that claim, or we are going to get caught. And I I think there's some guidelines in the medical records area that they're leading into that, the authentication. Um, they stress over and over again, timeliness, like you were saying, is now in the regulations. And there's a lot that people are going to have to walk through their own procedures of if you make an error and realize it, how do you line that out? What does your computer allow you to do? That you can say this is an error on this date. And there's a regulation in there that if you need to put in an addendum or find that error, you have a certain amount of hours, I want to say 48 hours, that you better be getting it fixed because they're going to be tracking all that kind of stuff. They don't want late entries 3 and 4 weeks later. That's not going to look good on your claims if they pull that record.
Yeah, the Medicare Integrity chapter really does a nice job of sort of outlining what
It
those
does.
steps
Yeah.
and procedures are. And, ultimately you have to have an EMR, electronic medical record system, that will enable you to meet those requirements. So relying on AI or relying on your EMR to solve all of these issues is, kind of fool's gold. You have to be the one who's advocating and driving those changes. And if they don't have a plan in place, it's up to you to create that workaround, so to speak. And I think AI and the question was great because it does really tie in nicely to preventing, fraudulent practices. The regulation that we'll speak towards is you have to have a unique identifier and a roster that's ultimately kind of outlining who's making the medical record entries.
Hmm.
So, I mean, think about it. Who's to say that my computer, right, isn't just sitting here that now someone else has access to sign my name and my license to a chart? There were actually agencies that the OIG
Yes.
found where people were doing data entry on behalf of the clinicians for whatever reason they wanted to stipulate. It could have been, just my intent was good, but I did it the wrong way, or it was totally fraudulent. The use of an identifier now that has to be entered in addition to the signature is a critical step, I think, for helping to prevent those sorts of abuses. It certainly isn't foolproof, but it just speaks to the level of integrity that you as an agency have to have,
Yes.
ultimately the level of detail that your operations and your day-to-day, duties are leveraged to represent that you're, doing it right. And that's where I think, to me, understanding the intent of the regulations helps it to be digestible and more easily applied without frustration. You can be burdened by this or you can embrace it. Either way, it's the rules of engagement, and we need to be prepared to do things the right way. And so that's the goal of all these webinars.
Well, I think when you look at, like you're saying, the authentication, and I could just sit here and say I've seen 10 patients today. But when you
Hmm.
look at the national $6.5 billion of fraud that they're tracing back to some type of home health or hospice, we have to be very alert. We're going to have procedures in there They're trying to help us get them at least started. And then I'm going to ask you back, Eric, when you have your compliance program, I'm assuming you're updating pieces like this within your compliance program as you can prioritize what has to go in next. So the governing body knows you're doing it the right way.
Yeah, absolutely. I mean,
Okay.
the policies and procedures around some of the medical record content, I think, are the more easy sort of black and white items to just add into your policies. But are you actually implementing it at your
Exactly.
intake level to screen
Right.
for the social security number or the taxpayer ID, which people don't know needs to be asked now, along with, another way to identify them. So,
Mm-hmm.
are we even approaching gender identity and sexual orientation, right? Which is required through the regs that we document
That
it
we do it
if
right
applicable,
under civil
so
rights.
again,
But I
we
think
got to
in
move
discussing this, even though we sit here and say, okay, as a conversation, this isn't going to be an easy part of your policy and procedure, to actually make certain that your staff is doing it is a whole different piece of the compliance.
Yeah, absolutely. I've had to look at, what we do for a day-to-day from a quality assurance and daily documentation standpoint. And have made a number of changes, from advanced directives and discussion of medication disposal. Those are elements that are important to be, reviewed and implemented timely, and to me are a high priority. But, what are you looking at with your quarterly discharge charts,
Exactly.
and how are you,
And have you
kind
updated
of,
your audits to start reflecting the new procedures and policy statements that are in there? Because they're
yeah.
wanting to see that you are actually looking at fraud and abuse, that you're teaching your agency all about it all the time, and that you're auditing. That's what they're going to look for so that you're in compliance. And so it's not
Absolutely.
just
Yeah.
going to be something we talk about. But are we putting medications on there? Are we doing the codes correctly? Things like that. Not upcoding. That old word that we thought had kind of gone away is back in again. I think in the
Hmm.
infrastructure itself, when I think of that, they want a brick and mortar wall, a 12-month lease. They want a public access restroom. They want operational equipment in there so that you can receive a fax. You can still, have enough paper to copy stuff of what you need to do or electronically get it out to your staff, because they didn't find that in some of the agencies. So they're actually saying this is how you build your office so that you're going to be able to have a good infrastructure. And,
And you,
one of the other things is, what if your medical records go down? It's finally in there in the regulation that if there's a disaster and you can't, for some reason, use your EMR, do you have procedures in place of how to do handwritten documents for a while? And I can tell you,
Yeah.
most agencies do not. And probably most people listening to us in a week are going to say, oh, no, everything's electronic. We'll be fine. Well, that might not happen all the time. So I think some of these regulations are really good for us to look at how we run things and how we support patients,
Yeah,
even though
absolutely.
it's a
The
lot of work.
contingency plan, yeah, you gotta plan for the worst and hope for the best, as my dad used to say, so.
and again, we're going to drill down, you're going to drill down a lot more on this in the webinar, get a lot more specific about things. So I have just one more question. Um, and it's going to come again from my business development background. I've decided now I have to have at least one question on business development sales.
Good. Good. That's good.
I don't care if it has anything to do with records or
We
not.
we love the business development side. Come on, you butter our bread, Mark.
But it actually does. It actually does apply to records, and it's something that I've had to deal with in my career. And the question is, and are we going to be able to do this with the emergency regs, the California emergency regs? Should someone who isn't directly involved in patient care be able to see the patient's record? And I mean, from a business development standpoint, lots of liaisons like to be able to give referral sources updates on patients. It matters.
So should they be able to, on, Monday afternoon, go in and look at the patients that have been on service for anywhere from 3 days to a week, just
Yeah.
ad lib whenever they want to?
Yeah.
My first comment would be, yes, there's a purpose to that. My second comment is we limit surveyors to things that are important. And maybe one of your processes should be, this is, as a liaison, what you can get to. And If you need more information than that, then join the IDT team. Be there. And then you wouldn't be violating the records. You'd be on hand.
Okay. Good point. Great point. Eric?
Yeah, I think, from my perspective, if you're associated with that patient's care in your consent forms, or an allowance of that, right? The benefit to having like a licensed liaison ultimately puts you in a much safer position to allow for all of that communication and fair, transparent accountability.
Sure.
Everyone in a company should be, trained on HIPAA, right, in the standards, and ultimately sort of where you start and stop in that access and availability standpoint. But the liaisons do have a role to know if a person is, doing well, doing not well, needs more
They
help.
have to know. Yeah.
They should be involved in helping to message some of that. I personally look at it from let me be a clinician, but also in a liaison's mind. If the doctor is not getting the updates that they believe they need, that is a care coordination issue, and that is not the liaison's job. That is the clinical operations. So I try and create a little bit of a divide there that I think is the clinical talk needs to be the clinical talk. The update talk is separate, right? Also equal when it comes to that relationship, but you just have to be, I think, very mindful of what you're willing to allow.
Great point. Great point.
Yeah.
Good question,
okay.
though, Mark.
Well,
How do you look for your next one now? Have you
I
got
got a
another one?
No. Well, yeah, I do actually. And it's the final thing. Just a quick rundown again on where we're going deep in the webinar. What kind of things am I going to come away with next week?
I think we've talked a lot about what is expected to be in your policies and procedures. My takeaway for most people would be this is a priority. You probably have a couple other ones like GSA and acuity. Have this in the background, start putting some notes together for it. So if you are in a survey, you can say, it's going to get done. It's just going to take me another 3 months to do it. And then, as you said, Eric, for the HIPAA and the training, that's annual now. We're going to have to do that annually. And remember that if the confidentiality statement and all that stuff has to be signed in orientation by the administrator, that you've had the training.
Absolutely.
So that puts more responsibility back on leadership.
Okay.
Those kind of things are quick takeaways to fix.
Okay. Great.
Yeah, that's exactly right, Sharon. There's going to be some really tangible, quick and dirty take-home messages that are quick implementations, quick wins. It will feel good to go through this, giant, book of business and come away with some really quick opportunities for success and implementation. And so this area is going to really kind of focus on that and, help to ensure that you're developed and sustaining, as an organization.
Okay. Okay.
Well, and I hope some of the questions that come in, even if we don't really all have a good idea, is just like this. It's like, have you thought about this? Have you thought about this? This works for us. And that develops your network within CAHSAH and your friendships. So, maybe that's our infrastructure.
There's still a lot more clarity that I think ultimately the state is obligated to provide us, and that of their surveyors. And so having the industry come together is going to benefit, the total arena that we all are playing in. So.
Exactly. And then if there's questions, Tanya takes them back to the state. So we have that closure, hopefully, sooner than later.
Our director of policy and
advocacy.
Yeah. Okay. Listen, folks, go to CAHSAH.org right now and get yourself signed up for the webinar. This was just a small taste of what you're going to get to whet the appetite. And here's the cool thing about these podcasts that I think you can develop a couple of questions, things that maybe you haven't heard or things that you heard that you'd like a little more clarity on or more information on. And you take it to the webinar and get it answered live. So go to CAHSAH.org right now to register. And again, because they'll be going much deeper on these critical areas of the hospice emergency regulations. So thank you again for joining us. This special series is presented by California Association for Health Services at Home. My name, as always, is Mark Wilson, Business Development Executive and Thought Leader. How do you like that? right?
Hey,
Thought
that's
leader.
good.
It got a nice ring to it, Mark. Yeah.
For our experts today, Sharon and Eric, and for all of us at CAHSAH, thank you for joining us at the table. We'll see you at the webinar, and we'll see you at the next podcast as well. Take care, everybody.
Thanks, Mark.
Thank you.